Good afternoon, everyone. I'm CJ Seitz, the Chief Justice, and with me today, once again, is Dr. Alfred Bacon. He needs no introduction since this is our fifth town hall for judicial branch employees. And without further ado, we're going to jump right into his presentation because we have a lot to cover today.
Thank you, Chief Justice. We'll move to screen share. And I appreciate another opportunity to speak with you concerning COVID-19. To be perfectly honest, I'd hope not to have this conversation with you again. And to be even more honest, my tone today might be significantly different than prior tones. I'm one of the many providers taking care of these patients. And even from afar, what you're probably hearing, reading is continued and progressive provider frustration with the critical illness we're seeing, with the quote, fourth surge we're now experiencing, and the frustration with managing a critical disease where we actually, at this point, many of us, in fact, most people in the scientific arena are truly convinced it's a preventable disease with a vaccine that is not only safe, but highly efficacious. And I would hope, and that's the discussion for others, perhaps, readily available. But I think it's good to take a look now at where we sit. I'm going to talk today about the current Delaware and national data, which shows a steep rise in cases. The Delta variant will come up in conversation. That's always a topic, plus a brief word on the Mu variant, the new variant. Look at vaccines in comparison. I do want to talk about children with disease and pregnancy, which are hot topics. We'll briefly have a comment about long haul and post-COVID syndromes, then review vaccine safety, masking, social distancing, and also the current Delaware judicial protocols. I really think that this disease has been 18 months in time frame for our experience. During that time, the scientific data that's been generated has been quite impressive. I would also add that the science behind the vaccine has been really quite crisp and really afforded the population of this country in particular, with all its riches, to have safety and move into a positive realm. Along with many providers, I'm increasingly disheartened by the degree of misinformation and data that is askew of what is rational to some extent. And I'd like to think that I was able to cut through some of that. There's a wide range of comments about what vaccine does this, what vaccine does that, but I will get down to the basic numbers, which are meaningful. And hopefully the data you'll see is validated. I use only what I consider peer review journals and organizations that speak with well vetted information. Current Delaware data, beautiful number, 76% of all Delawareans 18 and plus are vaccinated. That also means that 25% are not. And it's pretty clear that the unvaccinated Delaware population is a large population. And the reason that the quote herd immunity hasn't become more beneficial is that these are large herds that are grouped together in families and organizations. And once COVID hits one of those unvaccinated quote herds, it rips right through it. And we're seeing it just like we did in the prior surges.
Doctor, what is
the number of new cases daily? Yes.
If I could interrupt you, what is your current experience with hospitalizations? I mean, is what you see on the ground? We see 220 on here. Does that sync up with your experience?
Yes. I mean, the rise, what syncs up is the rise of hospitalizations since the end of July. Yes. Currently at Christiana, I don't know the actual number. On my own service, we have about 90 in the hospital. And I will also tell you, 88 of those are unvaccinated, frankly. The number of positive tests that are positive on a 7-day average has gone from 1.5 to 2.5%, now 7.4 over the last 4 to 6 weeks. Hospitalizations have risen. Deaths are somewhat flattened. I think a lot of that has to do with our ability to care for individuals with what I would describe as relatively high-tech, sort of high-tech interventions that do mute the severity. This is the United States trends. Surge 1, 2, 3, which was last winter, and now surge 4. And look at the numbers are quite prominent. And you can just see it rising. This is not just in the southern states, although they're driving the train. Those individuals travel through the country, and this is being experienced in almost every state. This is state of Delaware, percent of persons tested that are positive, from a low of maybe 4% back in June. As you can see, the number now is reaching 18 to 25% or more of individuals being tested are positive. That means if you think you have COVID and you go and get tested, you were probably wrong back in June. You're probably right in September. So this virus is circulating aggressively again. My own bias is it's due to relaxation of social distancing and masking, a return to quote normal. And I think the next 4 weeks, as young people return to school, it will be quite prominent. That's what the projections have shown. Looking at the state of Delaware, new cases in Delaware per 100,000. I will tell you that back in early July, it was 31 and 25 cases per 100,000, doubled by the first week, doubling every week. We now have 250 new cases with, once again, 220 hospitalizations. We had like 3 people being admitted each day with COVID back in July. My service in early August was 15 patients, and it now is up to 90. So it's very clear that this virus is being more prevalent. A comeback is ongoing, and I think the reasons are probably many, but I still think lack of social distancing, masking, and people trying to get back to normal. I can't fault humans for wanting to get back to normal, frankly. We all feel that way. So it's hard to fault people for that. Current hospitalizations, once again, rising now up September 5th, around almost up to 240 at one point. And being hospitalized for COVID is not a minor thing. In the early first 3 surges, the risk of death when you're hospitalized with COVID, about 10% mortality, which is actually a Christiana, that's the number, and it was as good or better than any other center in the country. I don't know what the number is now, but keep in mind that this is once you're hospitalized, you're at risk to have a myriad of problems, et cetera. But the unhospitalized COVIDs also will present later on with other post-COVID syndromes. And we'll talk about that briefly. That's an area that's under discussion and actually quite interesting, unfortunately. Never let a doctor say something interesting. That's always a bad sign. This is University of Washington Health Metrics projections looking at daily infections. And this is for Delaware. They do it for every state. And in early August, I saw this, and you could just see the projections suggesting a 4 to 5-fold rise of cases of COVID. And we're experiencing that. The numbers we have are bearing this out. These projections were correct. So somewhere between the baseline to the worst case scenario will be this projection, anticipating a surge that will likely peak sometime in the middle of September, toward the end of September. And I think this has to do with relaxed distancing, but also with school children. If you look at the data, it's children that are driving this surge, and kids are all going back to school, and they need to go back to school. The CDC has backed that up. The AAP, American Academy of Pediatricians, also backs up the need to go back to school as safely as possible. But keep in mind, young people 12 and under are all unvaccinated, and they are absolute cesspools. They are skilled at sharing secretions, and they will fuel the COVID disease in the unvaccinated adult population. This is daily infection rates and testing. This is hospital resource use. If you look at it over the summer, it's nice and quiet per se, relatively speaking. And then now, along with that surge, hospital resources will also rise. So it's not just a bunch of people at home feeling sick with a little cough and sniffles. These are sick humans coming in that are unvaccinated typically, using a lot of hospital resources. Half of our ICU is COVID again. And you know, a day in the ICU is $10,000 a day. And COVID, the cost of a COVID care case in the hospital, I don't really know what that is. I don't follow those numbers, but I will, you know, it's going to be 50,000 per case easily. But once again, you can say that's not my burden, but it's all of our burden and all of our responsibility. I mean, the health issues are more important than the dollars. And I think most normal humans would agree with that. But it's part of the use of resources that could be used for other individuals with ongoing medical needs. And in the high outbreak communities in the South, there's no doubt that people are being turned away at ERs because they can't get into the hospital. That cannot happen here. I don't project that'll happen here. COVID management has not changed at all because not much to change. Number one, if you are positive for COVID and you consider yourself high risk, the use of the monoclonal antibody infusion has been extremely successful. I mean, over 600 infusions in the Newcastle County area have been given, I'm sure of that. Haven't looked at the numbers lately. Combination agents, very effective, preventing hospitalizations, probably cuts down hospital rate by almost 75 to 80%. This is an excellent intervention. About $3,000 a shot, but it's an excellent intervention, okay? The vaccine is much less expensive than monoclonal antibody, obviously. It doesn't cost anybody anything. Remdesivir remains a drug of choice, and actually remdesivir is an antiviral only given in the hospital intravenously, has been shown to even improve outcome even better, decreasing mortality by at least 25%. So we've been using that, and it's good supply. Use of steroids has certainly been of benefit. That's helped patients. Immune blocking agents, which block inflammatory response. These are, once again, $3,000 to $5,000 to $10,000 a shot agents, but they work. It's sophisticated. It works. We don't want to use it, but it works. There is now some discussion.
Doctor, can we talk about things like vermectin and other things that people are reading on the internet that they can take prophylactically? Do you have some view on that?
I do, and I need to be cautious not to be too vehement. I've used ivermectin to treat my dog's heartworm, and I've used ivermectin in humans with what's called filariasis, which is parasites in the skin. It works, but it has side effects. The recent data was just collated by one of the publications I reviewed. There's zero benefit to ivermectin and significant toxicity to ivermectin. It's frightening to think people believe that and use that and want to access that agent in the absence of any true professional, competent infectious disease or scientific data. I've seen some, videos of cardiologists talking to state legislators about it. It is of no benefit, and I'd be embarrassed to even include it in the discussion, frankly. But I'm glad you brought that up. You're gonna keep doing this, and you'll really get me over the edge in a minute. Well, someone have to pull me off the screen. I like to balance this a little bit though, and things that fall into the won't hurt might help category, I'm happy to use, but that's the will hurt category. I'm not sure if you understand that comment, but it is. There is now a discussion of an oral pill form of antiviral medicine that will not be available for many, many months to treat this virus. That would be quite a large step. So this schematic shows the variant ratios within the United States. And this is back in May, looking at all the strains that were tested in the United States. The green being the P1 variant, the blue being the Alpha variant, B117, which is the classic, the first COVID we ever really saw, and the orange being the Delta variant. And as you can see, since May, the orange is now the predominant variant, and it is 99% of all COVID-19 virus in the United States. The two things we know about this is, number one, it has an altered spike protein that allows it to attach more firmly to your tracheal airway cells. And number two, it has a much higher concentration of virus in the trachea, making it more infectious. There is debate whether it makes people, quote, sicker or not, and that still is a debate. We will see many variants, and the mu variant is a new variant, and the viruses are obviously, your body has 1 million of these organisms, and of those 1 million, a certain percentage will have a mutation. And if it's a favorable mutation, the next person that gets it will spread that mutation. So these are really sophisticated genetic machines, and they reproduce readily, and they pick a variant, and we are selecting out these variants. The discussion about which vaccine is better against which variant is really a debatable discussion. We're going to cover that near the end, but now Delta is the predominant one. The mu variant is very similar to the South African variant from a few months ago, and it moved up from Venezuela, Colombia, now is in 49 United States. There is some data that it is less sensitive to neutralization from the vaccines. No doubt about that. That doesn't surprise me. However, I suspect the vaccines will be efficacious and work. So that doesn't mean don't get vaccinated because of the mu variant. In fact, it's more urgent to get vaccinated. So the the variant after the mu isn't resistant. There'll be more variants. You need to stop this now. I want to talk about children, not as a pediatrician, and so I'll be honest with you, but as of August 31st, the American Association of Pediatrics, there are 4.8 million children affected with this virus. However, in August, there was a 9% increase. Last week alone, there were 250,000 new children under the age of 12 infected with COVID. That number will rise and rise and rise. Now, in some states, this represents almost 20% of all new cases. I wouldn't be surprised if Delaware, that's the case. I don't know the numbers for Delaware. It represents up to 3.5% of hospitalizations, but only 0.24% of deaths nationally. And so these young people get sick, mildly so, but those with additional illnesses get sicker, but they still don't, quote unquote, die from this. Well, that's good, but they get sick, and you don't like seeing sick kids, and you don't know the downstream effects of this virus. There are a couple of things to talk about there. Now, the adolescents are another population, age 12 to 18. They are eligible for the vaccine. And of note is adolescents are an increasing percentage of those that get this virus and those that get sick. So remember, when I first talked about COVID with this group, there was an age-related death rate. Over 65, it was a frightening number. Over 55, it was 18 to 20%. 40 to 55, maybe 8%. 30 to 45, maybe 4%. It may not be a high percentage, but if you're that adolescent, you can get very sick. The data on unvaccinated adolescents suggests that in a high pandemic area, they're 10 times higher likely to be admitted than an vaccinated adolescent. So you're protected 10 times over if you're vaccinated versus unvaccinated as an adolescent. Number two, in some of these high pandemic communities, 20% of the ICU admissions are less than 17 years old with COVID. That's 1/5 of the ICU admissions are adolescents. We never see adolescents in intensive care units. Admissions for this population are up 5-fold since July. I guarantee you a month from now, they'll be up 10-fold from July. And 23% of adolescent admissions end up in the ICU. And 10% in one study were on ventilators. Well, that's just untenable and unsustainable, and it's just not what should be, so to speak. And that's my comment.
Doctor, can you just explain to everyone again what it means to be on a ventilator?
Yeah. So what happens with the COVID patient? They come in, they're on this little nasal thing, and their oxygen's pretty good. And they go, I'm feeling a little better because I'm in the hospital and you're taking care of me. And then about a day later, they go, I'm feeling worse. And they get this thing called a high flow, which is like shoving two hoses up your nose and blowing it into you. After a day or two of that, they get worse. They go to the ICU and have a tube that's the size of a garden hose put down their lung and put on a machine. The data on machines and ventilator support in the over 65 population is if you go on a ventilator for COVID and you're over 65, you're in the 50 to 25% survival range. That's not true of adolescents. For the most part, they're surviving this, but it's a horrendous existence. I mean, and keep in mind, being in the hospital is not benign. Once you're in the ICU, they shove a bunch of needles in your arms and your legs and put a catheter in every orifice you have. And the risk of infection from being in the hospital, which is what I do for a living, does go up. So there's no free lunch here. I just think that we know that over the age of 12, you can get vaccinated. I'd like to think they're readily available. And if you can prevent this, you should prevent this, obviously. And mechanical ventilation is extremely, it's a frightening concept for someone this age. Oh my gosh, I would be disturbed by that. So children, as I've said, 12 and under have sort of mild disease, asymptomatic. They easily transmit it to adults, often without symptoms. So these little cesspools are just breeding grounds, and they're going to bring it home to everybody. And that's what I've seen so far. The new admissions I've seen today, one was pretty clear she got it from her granddaughter, who brought it home, and she picked it up, and her son picked it up, and her daughter-in-law picked it up, and two of them are heading to the ER now after she's up on the step down with a thing shoved up her nose, and once again unvaccinated. I do think that the concept of co-illness, similar to adults, is important. We know that adults with certain diseases are predisposed to get worse with COVID. I think that's sort of intriguing metabolically. Like, why is that? It has to do with the way the virus attaches to the cell and the receptors for that. But in the adult population, if you have an elevated BMI, you're obese, you have diabetes, high blood pressure, or underlying lung disease, you're at high risk to get sick. Now, keep in mind, in the United States, we've had an epidemic of obesity in the young population under 12. So it's sort of ripe for the picking. And you're going to find that obesity in children, asthma in children are predisposing factors for hospitalization and clinical deterioration. And of course, there are plenty of individuals in the young population with congenital diseases, Down syndrome, who actually survive cystic fibrosis, who are now surviving much longer than they ever would have with really good care and doing well. They're at high risk to do poorly. Protecting those populations is really what I think a lot of this is about. There is one syndrome that's been identified in children called the multi-system inflammatory syndrome, MIS-C with COVID. It occurs weeks or even months after the COVID infection that can be very mild. And it's an inflammatory response in response to the virus. It turns on your immune system and your immune system attacks you. A big diffuse red rash, fevers, temperatures. It's a lot like rheumatic fever in kids and something called Kawasaki's disease, which is an immune disease. It affects multi-systems, lungs, heart, kidneys, all get shut down, even to the point of dialysis in some kids. It can occur weeks after disease. Now, typically these young people recover, but there can be scarring of the tissue and even longer term effects. So I think I think there've been no more than 300 cases reported nationwide. That's one disease that kids are getting, which warrants attention. So moving on to talking about the vaccine, which is sort of one of the big discussions here. There are 2 or 3 ways to measure how well a vaccine works. And when you read an article on this or you're reading the news about this, you have to keep these 2 different methods in mind. In a laboratory-based system, you can take the blood of a person who's been vaccinated and mix it in a test tube with the virus. And you can see how well that blood and the antibodies in that blood bind to the virus and, quote, neutralize the virus. Those are neutralizing antibody studies. They're really frequently used now to compare one vaccine to the next in terms of how much antibody does this vaccine generate? How well does this vaccine antibody generation neutralize virus? That's where you see the 46%, 95%, et cetera. The best way to do it is epidemiologically. Look at, okay, we have these 1 million people that have gotten, there are actually 370 million vaccines given in the US to date. You look at all those people who got vaccines and trying to figure out which ones got sicker with which vaccine and when. The United States struggles with that, but we do have some data to show that certain vaccines may or may not have more breakthroughs. I don't think that's well defined yet. So I would encourage you to be very careful interpreting breakthrough rates for vaccines. Now, Great Britain has an excellent system, and this is, politics aside, this is one of the reasons to have a centralized national health system. When COVID first hit, all of their data, treatment, vaccinations, outcomes, hospitalizations, follow-ups, are centrally recorded. So the Great Britain data led us through the recovery trial showing steroids were a benefit. And they've also led us through a lot of the vaccine data showing which vaccines are efficacious and how well they all work. So that's one benefit of having a centralized database. Our public health system is really struggling now under the weight of this epidemic and pandemic, and also following, I mean, frankly, I'm a fan of public health. They really had a lot of budget cuts, which everybody goes through, but so we're struggling with that. You can also measure the antibodies levels over time in people. And this is what's driving the concept of a booster vaccine. Pfizer has now demonstrated that their antibody titers drop over 8 months. And a third dose boosts those antibody levels even higher than they were originally. And that's leading the FDA to now approve a Pfizer, quote, booster vaccine as of September 20th. Moderna will have the same data. I'm comfortable with this. So when we talk about vaccine success, keep these issues in mind. Hospitalizations, 98%, I say 90 to be diplomatic, 98% of my people in the hospital and nationwide are unvaccinated individuals. And those are the ones getting sicker. And actually, I'm seeing some deaths there now. In the vaccinated, I've had a number of hospitalizations break through. Those have been with a wide array of vaccines, not one specific vaccine. And these people get sick and they're on the step down, they're getting some high flow. I've not had one get intubated yet. And I do think the vaccine helps, but they're often immune compromised. This is why a booster is recommended for anyone with immune system issues: cancer, chemotherapy, systemic lupus, rheumatologic disease. You can easily go get your booster if you can check those boxes at the pharmacy.
So, doctor, just to summarize, I think what you just said, and that is that there are breakthrough cases. You are seeing some of those breakthrough cases of vaccinated people in the hospital, but they trend towards people that are immunocompromised rather than someone who's generally healthy. Is that correct?
Yes, exactly. Yes. So there are a number of things sort of floating around right now that need to be addressed. Number one, this current, lay publication comment: Moderna makes twice the antibodies as Pfizer. Well, their titers may be higher, but is it as good an antibody? Does it give you a good neutralization? Clinically, in terms of epidemiologically, I don't see any difference in Pfizer versus Moderna, scientifically or in breakthroughs. And I think it's way premature. I mean, we're only 18 months into this pandemic. Hopefully, we'll be able to stop in 19 months. But the vaccines came out in January, February of this year. We're only 9 months into these vaccinations. So the full database on vaccinations is really yet to come to fruition. So all these things getting thrown around, I would be very cautious interpreting. Now, it is true that about 8 months post-vaccine, most titers do drop with the mRNA vaccines. And I think Pfizer, there'll be a third dose, and Moderna probably as well. What's interesting is the J&J vaccine, when it first came out, there was a great discussion about it's not as good a vaccine. I've seen some breakthroughs, but it looks like the antibodies generated by J&J may last longer and may be a little stronger in neutralizing. So the tortoise and the hare model may be appropriate here. So I think J&J remains a very competent vaccine, and I'm not going to diss that vaccine at all. And keep in mind, the goal of these vaccines is not to keep you from getting a cold or a sniffle or a little symptoms. It's to prevent your death, hospitalization, and severe disease. All these vaccines do that. They all do that. When you talk about overall clinical effectiveness of the vaccine, it's if they get sick or not. So we're seeing maybe J&J 67% efficacious, means some people can get sick with it, yes, but not severely ill. Moderna 66 to 95%. This is against the Delta, by the way. This is all discussing the Delta virus. 95% efficacy in some studies, 66% in others. People get sick, mildly ill, maybe a breakthrough. They're not dying, they're not going to the hospital, and they're not having severe disease. That's a critical discussion. So you can talk all you want about Pfizer being 42 to 96%, but the mortality of vaccinated humans remains less than 1%. And I just think that you got to go through the clouds here. Because there's some debate about efficacy, that doesn't mean you don't get vaccinated. That they work. The only thing we have against this virus is successful vaccinations, and that is available for you, or your family, or your friends, or your 12 to 17-year-old adolescent in your household. They remain very safe. 370 million doses have been given nationwide of these vaccines. They make you sick. Malaise, fever. I had arm pain for days, weeks, 4 to 5 days of illness, headaches. That's all true. You can make a case for that, suggesting they're going to work better, but I don't think that's true to say yet. We do know about the thrombosis syndrome, where predominantly women age 18 to 49 with the J&J vaccine were identified as having some thrombotic events. Usually 2 to 4 weeks, up to 3 to 4 weeks post-vaccine. And that included some strokes. So there's no free lunch. Once again, anaphylaxis, which is a rare, severe allergic phenomenon, does occur. There's a syndrome called GBS, Guillain-Barré. It's a neurologic reaction after a vaccine. If you remember the swine flu vaccine, if you're old enough, there was a high incidence of this neurologic event post-vaccine. You get vaccinated, and your body's immune system turns on, and that attacks your own your neurologic system, and you can't function. That's really scary, and this overwhelmed the swine flu population, so much so that we stopped dosing with the vaccine. The Guillain-Barré syndrome is less common with this vaccine than with influenza vaccine, 0.01% to 0.1%. Myocarditis, which is inflamed heart muscle, occurs. There have been 35 reported cases that I know of, and occurs with the mRNA vaccinations. And it can be prominent. Your chest hurts, you have fever, you have inflammation. The data does show that you're more likely, if you're unvaccinated, to get myocarditis from the COVID virus overall than you are to get from the vaccine. So that's a non-issue in my world. Deaths from vaccine, a lot of lay population press reporting this. I've not seen that here in Delaware. I've not seen a death from vaccination with over 1 million doses given in Delaware. And then booster reactions. I think we're going to see people getting boosters, which will soon be called third doses, not boosters, having a lot of reaction to it. And I think that's healthy. That's good. You know. Pregnancy and COVID. All right.
So doctor, before you move on from that last slide, you listed a number of the side effects of the vaccine. Could you just put that into some kind of context for us again about, you know, what of all the percentage of people that have been administered the vaccine, I mean, what percent of the population is seeing any of these that you just listed?
Less than 0.5 to 0.25%.
All right. So, and any given person's risks of one of these side effects of the vaccine is pretty darn low.
Exceedingly low. So low that it may be another 2 years reaction of the number and percentage. That's a good point. I don't have that number, but it is exceedingly low. And that sounds like an off the cuff comment, but it is. Looking at pregnancy, the database from the CDC in August reviewed pregnant women with COVID. 105,000 pregnant women were infected with COVID over the last 18 months that we know about. Of those, 17% were hospitalized. That's a really high. I mean, normally only 1.5 to 2% of people with COVID get hospitalized. So this is, 6 times higher. So if you're pregnant and you get COVID, you're 6-fold more likely to be hospitalized. High percentage of these pregnant women become critically ill because pregnancy, as you know, is not a normal state. It's an immune suppressed state because your immune system is trying not to reject the fetus. So the immune system is kind of turned down. So COVID can be more aggressive in the pregnant population. It leads to a high percentage of induced labor to reduce maternal stress. Of these pregnant women admitted to the hospital, 25% went to the ICU, 124 deaths. And they found actually with pregnant women with COVID, there was no increase in miscarriages, which I'll have some data on that in a second. So when you're pregnant, you need to get vaccinated. Pregnancy is one of the conditions people say, oh, I don't want to get vaccinated because I'm pregnant. I'm not that individual. But I also think that there is data now to support getting vaccinated in pregnancy. I've reviewed this again for this discussion. Looking at 36,000 women who were pregnant at the time of vaccination, large number of myalgias, fever, local pain, just like everybody else. No additional issues acutely. Of the 4,000 vaccine recipients who were pregnant that were followed, 900 had gotten to completion of pregnancy at the time of this discussion. 13% had fetal loss, which is miscarriage, which is the same as a non-vaccinated population in the first 10 weeks of pregnancy. Slight unimpressive, I mean, I'm not the person, so I shouldn't say that, increase in preterm births, and 3.4% was small gestational size, which is the same as the general population. So in theory, of those 4,000 pregnant vaccinated women, and I like to think of the 36,000 as a representation of that, there was no difference in outcomes of those pregnancies, vaccinated versus non-vaccinated. So currently there's no evidence of harm to fetus or baby with SARS-CoV-2 or with the vaccine. There's no evidence of transmission of the virus from mother to fetus. And in fact, if you are infected, and if you do get vaccinated, you will pass that antibody on to the fetus. There is some association of infection with SARS leading to preterm delivery 3 times higher because of fetal stress. But it's really important to notice that of women who are pregnant with SARS-CoV-2, much higher risk of being hospitalized and in an intensive care unit. Nature is a superb journal, and this is crisp information. So if you are pregnant, there's no contraindication to getting vaccinated. no reason not to get vaccinated, and it has better outcomes than if you get naturally infected.
And doctor, how about for lactating women?
You know, there's no doubt that there's no known contraindication to lactation and breast milk use during with vaccination in particular. And I don't know the answer to if you have COVID, but in theory, it would be safe because you'd be passing the antibodies as well. That was an answer from a non-OBGYN, frankly. So just take that. I do want to comment a bit about the quote long haulers with COVID. I've actually seen a few of these in my office, and it's really intriguing in that up to 30% of people with COVID-19 disease will become long haulers. I mean, 6 months post-disease, they're having significant clinical dysfunction, and many of them are struggling to return to work or performing activities of daily living. And what's really interesting is this is not related to your severity of disease. You can have mild COVID disease, not even go to the doctor, not feel that sick, and develop long haul COVID. It's related to some metabolic dysfunction and probably some neurologic dysfunction from the virus. That's all I can say. And actually, there's not much else known about it. So even with mild, unimpressive COVID, you could develop symptoms for 6 months or longer. These symptoms are sort of vague, but they're significant. Fatigue, exhaustion, can't function. Dizziness, what's called dysautonomia, which means your neurologic system isn't functioning well. So when you stand up, you get lightheaded. When you turn your head, things don't seem to fit. Breathing issues. You know, the ones I've seen, they have excellent oxygen levels. I mean, their O2 sats are good. They look great on room air, but I can't breathe. I'm short of breath. It's a sensation of not breathing well. That's an awful sensation to have. And then memory loss and fogginess is clearly part of this phenomenon. And that's a strong part of it, almost a hallmark of it. So we don't know the true factors, but it's clearly evident this happens. I don't know whether this is something that occurs if you have a breakthrough versus unvaccinated, but it's pretty clear to me if you're vaccinated to prevent disease, this is less likely to occur. So what about this booster vaccine discussion? Well, we do know that the immunosuppressed, I've said, should clearly get a booster or additional shot. And that's easy. I mean, all my patients with immune disease that have gone to get a vaccine have gotten it readily and quickly. It is suggested that you wait at least 4 to 8 weeks after your last dose of a double vaccine. Do the antibody levels decline? Yes, they do, 6 to 8 months. I'm not sure how clinically relevant that is yet. We don't know. It may be years till we know. What is interesting is the J&J vaccine titers or levels remain high for quite some time. So even though there was some discussion of J&J not being as strong, those titers stay higher and they neutralize just as well or better long-term. So I'm actually not uncomfortable with the J&J vaccine. We are clearly awaiting guidance on this. And this is what's going on with the FDA and the government. It's pretty clear that people want to get this booster out there. And it's also pretty clear the FDA hasn't officially approved it except for the Pfizer booster as of September 20th. I think we'll see boosters for all agents at some point in time. I don't know when. I just don't know when. So I also think that people that are eager for booster, that's a great population. There are people that already got the vaccine and they're being cautious and doing many of the right things to avoid disease. I think we also, the WHO has come out with halting boosters because they want to get everyone their first dose to start with. And so that's another issue. What about exposure history? This is going to be important with return to school and return to the workplace. If you are a vaccinated individual, you're vaccinated, doesn't matter when that happened or where you sit, and you come in contact with a COVID individual, less than 6 feet, more than 15 minutes, less than 3 feet in the school environment, you do not need to quarantine unless you have symptoms. So you can continue to do your daily activities, go to work, go to school, etc. However, it is recommended to get tested 5 days post exposure. And if you are positive at that point, quarantine. I've had some experience with patients with this. Routinely, the test is negative at day 5. If they have symptoms, occasionally they'll be positive. So if you're vaccinated, this is really business as usual unless you have some symptoms. And if you want to be cautious, and some environments are cautious with ongoing testing, I think that's one of our last slides is that discussion. If, however, you're an unvaccinated individual, keep in mind, adolescent or adult unvaccinated, or a 12-year-old or under unvaccinated, as they all are, and you come in contact with someone with COVID-19, you must quarantine for 14 days. That's the incubation period of COVID. So sometime from day 2 to day 14, you may become sick. And during that time, you cannot return to work or school for 14 days unless, and this is a caveat that CDC justifies, you may return on day 7 if you get a test on day 5 that's negative. So you'll find testing day 5 post-exposure or weekly in some environments. This is designed, now keep in mind, the rapid test is not as good as the PCR, and I'm going to talk about testing with the next slide, I think. So these are the current guidelines for those that are vaccinated with exposure and unvaccinated with exposure. So I will guarantee you, with school starting, we're going to have a lot of kids home from school. A lot of kids home from school. And I think that's going to be a big issue with childcare, with exposures, with family exposures, grandparent exposures. So that once again means if you're a parent or a grandparent of a 12-year-old or under, you get vaccinated, you're protected no matter what happens. COVID testing remains about the same in terms of strength and scientific validity. Number one, the PCR test, shoving that thing up your nose. With the RNA PCR study, it takes over 24 hours, highly sensitive. It is the gold standard for documented COVID-19 positive status. I have seen false positives. They're really rare, and there's some select circumstances. And if I see a test that's positive and I don't believe it, I can communicate with the laboratory. There's certain things called cycle times and the way the test is performed, which can tell you if it's likely to be false positive or not. In the setting of a pandemic with a rising number, every positive test is a positive test. And that's true of the antigen test kits. These are detecting surface proteins. The beauty of the antigen kit, and this is why it should be used regularly, is a 15-minute turnaround. So you're giving up some security of the sensitivity, sometimes up to 30% false negatives, but in the active illness group, it's not that high. It's excellent for screening, and therefore it's being used for screening. But keep in mind, there are false negatives. If you're a COVID-19 infected person, if you have active disease, right, you must isolate for 10 days from first symptoms. That's true vaccinated or unvaccinated. You do not need a negative test to return to work or the school environment. 10 days is it. I got sick on September 1st. September 11th, I can return to my environment if I had mild to moderate disease. If, however, you have some underlying immune disease, then that number is 20 days. And that's held up now for at least 8 months, 7 months we've been doing that at least. So if you're very sick with COVID, hospitalized, severely ill, or have immune disease, you must isolate for 20 days, depending on how sick you are in the hospital. It is also true that natural disease antibody levels are lower than those of the vaccine. So everyone who has had COVID-19 must get vaccinated. And I think at least 4 to 6 weeks post natural disease. I have to look that number up. But keep in mind, I have a number of people who call me and say, well, I'm going to get an antibody level to see if I have immunity before I get vaccinated. You're wasting your time because those tests are not very good. And I would never use that to determine vaccine or not. Some primary care providers are sending people off for those tests. I use them to see if someone had COVID or not, if it's a debate. I don't think we know the true antibody titer that's protective, like we do with measles and mumps and rubella. We know about those vaccines. We really know that stuff. This disease is still too young that I think you can grasp onto that and grab it. But I do think that even if you've had COVID-19, you must get vaccinated. Activities to watch out for. Restaurants remain a high risk event. Sitting in a crowded restaurant surrounded by unvaccinated people, I'm uncomfortable even as a vaccinated human. So keep in mind that the safest environment is outdoors, no matter what, vaccinated or not, limited numbers in your group, 1 or 2 people, and the optimal experience is to be outdoors, but if you're indoors, wear a mask to get to your table and try to eat only with vaccinated humans, at least another 4 to 6 weeks as we get through this surge. Air travel remains a moderate risk. I advise wearing masks, hand washing solutions, I do advise not to eat on planes. I mean, eating is a really high risk exposure. You're just spewing stuff everywhere. Most of it, I'm not that bad, but some people are that bad. I am pretty bad when I eat. So be careful in air travel. I used to advise people to wear face shields when they traveled on airplanes back in a year ago in December when things were really taking off. I suggest if you wear glasses, that's great. And a mask, that's great. Events, outdoor ideal. That's still the case. I refrain from large indoor events, and I will share with you that I've canceled a large family gathering 2 years in a row now, with people coming in from out of state and travelers and family members nearby, a lot of high risk people, even though they're vaccinated. I think that my bias is being careful. There's nothing wrong with being careful. If you choose to say only have vaccinated people, there's still some risk in that, by the way. It's smaller and safer, but it's all about mitigating risk. How far do you want to go down that pathway? I don't think you're going to ever see the state mandate shutting down restaurants or shutting down gyms again. It just, my own comment is politically that's too difficult to do, and it's hard to do. But I don't participate in those discussions. So at this point, I'll comment that number one, this is the disease of the unvaccinated and children. And it is, I mean, there's still 250,000 Delawareans that are not vaccinated, mostly children. This disease will continue to circulate, make people sick. We'll see breakthroughs and we'll see death. The vaccinated do remain at risk for disease, mostly from their host issues, but data being thrown around makes me feel good. I have a 1 in 10,000 chance of getting sick if I've been vaccinated. That feels really good. A 1 in 5,000, but those numbers are just flying everywhere. Pregnancy, clearly you're at risk for high risk for disease and progression of disease and preterm labor. The vaccine is extremely safe. Extremely safe. I do expect vaccine to be approved for those under 12 by December. That is the sort of grassroots comments. We still don't know the long-term effects of COVID, this long haul thing. We'll see more and more of it. And we will see continued additional strains. The mu strain I briefly commented on, there'll be another strain. There'll be the XYZ strain. We will see more and more and more strains. The only benefit to more strains is that as a virus gets more resistant and uses more of its energy to become resistant, it may become less dangerous. So as bacteria go down the branch of more resistance, they sometimes lose their virulence because they only have so much energy to spend doing things. That's sort of a philosophical comment. Mu strain may make people sicker. There's some discussion about that, but this is so early on that to comment about what the mu strain is going to do, I can't say. I will tell you that if everyone was vaccinated, we wouldn't even care about the mu strain right now. Right? We wouldn't be having this discussion about the mu strain. So the Delaware judicial COVID measures, this is a slide obviously from the Judiciary. Number one, mask use, covering nose and mouth, restored because for all visitors and court staff. And I think this is obviously something I've talked to people about. If you look at that University of Washington health metrics curve going upward, you got to hit it before the curve gets there. And that's critical. And that was done here and that's appropriate. Social distancing continues to be encouraged in the facilities. Plexiglass barriers. There's some discussion about whether those barriers hold in air. Keep your stuff away from me, And Chief Justice continues to urge remote proceedings during the pandemic. There is a plan, and I'll defer this to the Chief Justice, to initiate the proof of vaccination or submit to weekly COVID tests, which is a mandate many businesses are going to, and I fully back that if you're not vaccinated, weekly testing can be a benefit to prevent disease, to minimize risk of disease to others around you. I don't think that's occurring yet. The time frame of that, I think I'll defer to the Chief Justice.
Doctor, thank you very much. Yes.
That I'll stop and open up for questions.
Right. So, Doctor, thank you. The time frame is going to be delayed on our testing because of supply chain issues with the tests. We were using a vendor that, or had planned to use the vendor that was doing other statewide testing, and apparently everybody now wants to get tested. So we're working on the supply chain issues so that we can get the tests in the courthouse. It's going to be delayed, but we are going to implement that as soon as possible, as soon as we get the tests through the supply pipeline. I have a couple questions, and Doctor, I know you have other calls on your time here, so just we'll hit on a couple here. This is a really good question, and you and I have talked about it, and that is, how do we convince vaccine reluctant people to get the vaccine?
First of all, I talked way longer than I thought I would talk. I'm a little sorry about that, for those of you having your coffee. That's a topic of discussion among every arena in public health. Vaccine hesitancy has been studied, and there are 5 groups: those that are waiting to see what happens with their friends, those that are nervous about the vaccine, making them take a day or 2 off, those that actually, there's a 5% population that don't believe COVID is even a disease, which I think is intriguing. But then there are groups that are hesitant because they're fearful and they're distrustful of sort of mainstream medicine. And you know, I hear that, and that actually makes sense to me in terms of how some populations have struggled with quote mainstream medicine and the elitism of medicine, putting them in uncomfortable positions and not thinking about their needs. I have to tell you, I don't think that's an issue here at all. We have good science, we have good data, we have availability, and the safety of this vaccine is incredibly impressive. And we prevented polio, measles, mumps, rubella with excellent vaccines. I think as I've seen people get sick who are unvaccinated, they pass that on to their families. And unfortunately, there's no doubt that individuals have shared their, I wouldn't say remorse, but shared the fact they wish they'd been vaccinated when they're in the ICU looking at these devices we're about to use. So I think it's a question of trusting who's standing next to you. And if you're a friend who has a coworker that's not been vaccinated and you have, and you're a colleague and you can communicate that to them, like, I got the vaccine, I think that's really healthy. And this is a citizenship question in some ways too. We value personal freedom and individual freedom. There's no doubt about that. But I think, quite frankly, unvaccinated individuals are risking the health of others, including their children, in this setting. And that to me is disturbing. So I think you need to look at the big picture, you know.
Right. And just one more question, because I know you have to run. What for children, and I know you're not a pediatrician, but for children and maybe for adults too, in the unvaccinated population, what signs should you be looking for to kind of take it to the next step, and rather than see if you get better at home, to actually go to the hospital? In other words, what should parents be looking for? What kind of symptoms to say, gee, I really need to take my kid to the hospital because I think they've got some serious COVID condition that requires a higher level of care than just waiting and watching?
Yeah, young children get sick very fast, and they can look well but be sick. And I think the key is, and frankly, the comment any physician will make is, if you're worried, take your kid to the ER. Let them make the decision for you. Clearly, a fever that continues for more than 48 hours unabated, and any question of cough that continues or breathing problems, a child that's too tired to do something, those might be triggers. But frankly, and actually, the pediatric ER situation in Delaware is excellent. I mean, the Nemours is an excellent ER, and I have colleagues that work there that I think it's an efficient ER. So, and they'll say the same thing. I mean, they want to see people get care when needed. So don't hesitate, you know.
Okay, that's great. Well, Doctor, thank you so much. I know we have a number of unanswered questions, and sorry about that. Unfortunately, I think if your predictions come true that we're not going to peak with this for another 4 to 6 weeks, I think we'll probably be having another town hall.
Appreciate that. Thank you for the heads up.
Okay. So, Doctor, again, thank you so much. Your advice has been incredibly spot on and reliable for the judicial branch, and we appreciate it very much. So thank you very much. And this concludes the town hall.
Thank you. Appreciate it.